Good evening, everyone. I'm Bruna Barbosa. On behalf of Western New South Wales PHN, I welcome you and thank you for taking your time of this busy time, of your busy agenda. I would like to start tonight's meeting by acknowledging the traditional owners and custodians of the lands on which we are meeting tonight. I pay respects to all First Nations people and acknowledge elders past, present, and emerging, and recognize the continuing connection to land, water, culture, and community. I extend that respect and warmly welcome all Aboriginal and Torres Strait Islands Australian who are present tonight. Thank you for joining us. Now we'll do just a bit of housekeeping. We please ask you to type your full name in the chat box when you log in or send an email to our team in order to record attendance. Please mute you if you are not speaking, and to ask a question, we please ask you to pop your question on the chat box or raise your hand virtually. Tonight's meeting will be facilitated by Dr. Ivy Chua. She's GP with Double Family Doctors, Chair with Western Clinical Advisory Council, Western New South Wales PHN, Rural Co-Chair of New South Wales Health COVID-19 Primary Care Community of Practice, Clinical Editor for Western New South Wales COVID-19 Health Pathways, RCGP representative on the THNZ Multidisciplinary TTS Guidelines Committee, and she's involved in the provision of shared care for COVID-19 patients at recent residential aged care facilities outbreaks in Double. And this meeting will be presented by Dr. Mel Berry. She's Medical Director, Clinical Quality Safety, Emergency Physician with Orange Health Services, Western New South Wales Local Health District. Dr. Evie, I will hand you over to start the update. Thank you for being with us tonight.
Thank you very much for the introduction, Bruna. And can I just start with saying that thank you to all participants at tonight's meeting for giving up your Friday evening, very much so to the presenters from across Western New South Wales Local Health District, Far West Local Health District, and we've got our PHN support, and of course our important GPs right across the region. It is a fairly critical time in COVID care right now. Lots of rapid changes happening week by week, and we hope to be able to keep you updated via a series of emails as well as webinars over this upcoming period. I'll just begin by sharing my screen, and hopefully this behaves itself. Okay, so here we are, COVID-19 update on the 14th of January. What we'll talk through are a series of activities that have changed in the past week. So how we're now managing RAT positive and PCR positive patients, which is quite a departure from what we talked about even just a few weeks ago. An update on Sotrovimab and Budesonide therapies and when they're indicated. How we might escalate care to our partners in the local health districts if required. How to access specialist advice for COVID clinical advice, some patient resources that we can share to make life easier for our patients, and last but not least, managing healthcare worker exposure, and that's may well be a growing issue in these upcoming weeks. So to begin with, we'll talk about management of the RAT positive and PCR positive patients. I think everyone would be aware by now, and hearing the news that people have been able to register their RAT positive results on the Service New South Wales website and app as of mid this week, and those numbers were certainly counted in the daily count, or presented in the daily count yesterday. I'll hand over now to Dominic Spork, who's an essential part of the Western New South Wales LHD COVID care in the community team, and she'll give us an update on how that looks at the moment. I'll flick over to the pathway. So these slides, by the way, will be shared with everybody so that you'll have a chance to access these links and have a further perusal of them in the next few days. But we'll just jump out of that one for a second and take you across to what this protocol looks like. So almost hot off the press, 12th of January, this flowchart was updated. So handing over to you, Dominique.
Thanks, Ivy, and thank you to the PHN for inviting me to speak tonight. I'm one of the clinical leads of the COVID care and the community team with a nursing background. So I guess I was invited to talk about the changes that were introduced by the Ministry of Health that went live on the 12th of January. Prior to this, you would know that there was a group of people that had been determined as the self-managed. So that was the younger than 65, greater than 3 months, doubly vaccinated. Now the ministry is basically going from the approach of, rather than the virtual services being a opt-out service, it becomes an opt-in service, and everyone is deemed a self-managed patient. And as we go through the flowchart, that will kind of explain a bit more. So as Ivy suggested, RATs are now able to be registered through Service New South Wales. And of course, people can still have their PCRs done as well out in the community. So if a patient has a positive RAT test, they'll register it in the Service New South Wales app. There's a short survey, short questionnaire on Service New South Wales app that asks very basic questions that helps flag if a patient is high risk. If there is any increased risk identified in that initial survey, a second detailed questionnaire, which asks almost about 20 questions to the patient, asking things about their chronic illnesses, their vaccination status, are they pregnant, goes into a little bit more detail, like how many medications are you on. That survey is set out by Medibank. So Medibank have been employed by the Ministry of Health to do that triage. And by that secondary survey being done, even higher risk patients are identified, and then they're then fed back to the LHD for management of that higher risk patients. At this point, we're not 100% sure what the delay is. So from when the patient gets the initial lab notification that they're COVID positive, for all the other steps, we're not 100% how long this is going to, how long each step is going to take. However, we have seen people over the last couple of days who have been doing the secondary survey, and we get a twice daily data dump from Medibank that we then have to sift through and work out who is high risk, and we are then calling the patients. We then will, from a CCIC point of view or COVID care in the community point of view, then go on to do a further triage assessment on them and work out, are they suitable for a MAB? Are they actually high risk? What we kind of need to look at from there. So I guess what's most important, I think, for this group is acknowledging that now everyone is on this self-managed pathway, and it becomes an opt-in rather than opt-in rather than an opt-out service. And that I think in the initial text message that they get, the second text message that they get from the first message from the ministry after the lab positive, it tells them to contact their GP. It also tells them to contact the state 1-800 number if they need to, but the state 1-800 number is averaging about 7,000 calls a day. So it is a lot, and potentially they're going to have to sit on hold for a while. So I think GPs will, I'm sure it's already started, but even more increasing phone calls coming forward. I kind of skipped a step there, but if someone is I guess you say, after that secondary survey that they complete deemed low risk, they will be sent back to the self-management group, and we won't know about them from an LHD point of view. We'll only find out about those high risk, so, you know, the chronic illness, the pregnant people, anyone. We are finding out about the unvaccinated people that do have chronic illnesses that are suitable for the MABs, and they're coming to us. I'm sure you also know that just before Christmas, the change for the 7-day isolation period came in, and when the patient gets their positive message, they also, on that same day, get their de-isolation certificate, which is dated 7 days from their positive swab. The reason the ministry decided to implement the de-isolation text message on the day 0 or day 1 is because the local 1-800 numbers and the state 1-800 number were getting absolutely slammed with questions about de-isolation. And so they're hoping that by sending the de-isolation certificate out at that very early point, there won't be so many questions to be asked by everyone. As with previously, we can, from that clinical de-isolation point, once they're on the LHD, we're either currently looking at either a 7-day, 10-day, 14-day or 20-day discharge, depending on the ongoing symptoms. Are they immunocompromised? And we continue to do that assessment for discharge. And that remains a clinical assessment at this point, not an automatic.
Have we lost Don?
Yeah, I've lost her. Can't hear her. She's frozen.
Whilst Dom logs back in, I might give just commenting to the unnoticed that Alex has written in the chat about what happens on the technologically challenged, no internet, no mobile phone. Look, this is exactly correct, Alex, and anyone else who's thinking this. So this model is really a disaster model. It's trying to take and encompass as many people as possible in recognition that all the virtual models, as good as they were unable to contact the numbers of patients that were coming online. Sorry, thanks, Dom. I'll let you continue.
Sorry, thanks for taking over, Mel. Do you mind scrolling down to the next slide for me, please, Ivy? As Mel has kind of suggested, I think that I see a few comments happening in the chat already. I think, you know, this is an ACI, Ministry of Health-led document. It's always tricky for our networks and our rural sectors when documents like this come out. And we did try to escalate similar concerns that have been mentioned in the chat as well. So this kind of just gives an overview of the protocol. So as I said, they'll have the low risk patients will do the questionnaire, the first questionnaire in Service New South Wales, which will identify if they need to do the secondary online questionnaire, which Medibank send out, and then it comes back to the LHD, yes or no. I guess from a ministry point of view, now the people that are considered high risk for both adults and children. So this pathway is for across the lifespan. They're not separating them out anymore. Is the immunosuppressed, chronic and complex conditions, pregnant and children with severe obesity. When they're talking about serious chronic and complex conditions, they're kind of just in that bottom box. Sorry, Ivy, thank you. They mention what the definition, like kind of narrowing down that definition. So seeing a specialist frequently, taking 4 or more medications, needing help with their breathing, other equipment, or severe asthma. Ivy will send out this link to you guys with the slides, but it is a really good tool to kind of just understand from the ministry point of view what is happening. In the first couple of days of this going live, certainly there's teething problems. We know, like, we're getting constant changes from the ministry level. I think, you know, every 3 to 7 days, we're getting a change that is really drastic. So trying to keep up with that has been really hard. But I think this is a really good document and it really pulls everything together. Then just to add from a CCIC or LHD point of view, we're still kind of continuing our same processes at the moment, looking after the high and very high patients. And that kind of has stayed the same. We haven't made many changes to that. And I guess as the patient number increases, we'll have to look at that because it's probably not sustainable forever. But at the moment, we're still able to provide, I would say, very nice care to our high and very high risk patients. And that's me.
I might just make a couple of extra comments about the care that we're doing. So eventually patients do fall into the patient flow portal, even if they haven't, particularly anyone who's had a PCR does still go on the patient flow portal. So we're able to follow up those patients as high and very highs. The RAT patients, because they don't have an imprint on the patient flow portal, mean they have to self-nominate through this way and can only nominate as being a higher risk patient if they go through the detailed questionnaire. In terms of the service that the virtual service is offering, so we used to have a very complex service that was providing food, pharmaceuticals, Indigenous support, mental health, drug and alcohol support. We still have many of those arms, but not as much. We just don't have enough manpower essentially to allow for the fact that this could be almost 100% of our population. So it's 270,000 patients, are essentially minus about 5,000 now, or possibly more now, are vulnerable because we know that Omicron, despite vaccination, you're still vulnerable to getting it and possibly not seriously and likely not seriously. So that's good news, but you still may feel pretty unwell and have flu-like illness and need to have some sort of services. So we have still got services set up for some patients, but they're just for the much more vulnerable patients. So we still have, we've just been working with some of our colleagues with the DPI in setting up how to send out monitors and we're working with Resilience New South Wales and food banks, and I've worked with the Indigenous Directorate with our LHD to still be providing pharmaceutical delivery. We just don't have as much as we had previously, but we're trying to do the best we can. We're still providing cultural Indigenous support, and also our Indigenous health practitioners are also doing risk assessments with Indigenous patients. So I feel really comfortable that they're doing that, and that's excellent. But as some of the other doctors are pointing out, there are risks within this model, and unfortunately, as is always the case, patients with less health literacy, less access, always miss out, and I feel like this is a problem. But we're trying to do the very best we can within the realms of possibility, essentially.
And just to answer, sorry, Mel, I just see Alexander's question, which kind of ties in with that about no mobile phone. If it's someone that is has a PCR and they put a home phone number down, they'll come to us regardless so that we can touch base with them, because we know that if they don't have a mobile phone, potentially they haven't even got a notification that they're COVID positive. So those patients definitely come to us.
Thank you, Dom, and thank you, Mel. Can I invite Becky? So just for the whole audience, because we do have GPs from both the Western LHD footprint and Far West LHD footprint. Becky, are you able to unmute and fill us in from the Far West perspective, what the COVID community service looks like with your LHD at present and in the next little while?
Ivy, I
Becky?
think Becky was having some problems getting on. Mel Welsh is there though.
Mel, are you able to step in, or Umit, would you like to speak on Becky's behalf?
a little bit, and if Becky can get in, then she can take over with any details. But certainly in Far West, we have sustained our community response team in small numbers. So we, like Western, we haven't been able to keep everything going that we had going before. But we are still seeing basically all the patients that need to have that input and supporting those high risk consumers through their journey. We have had some problems with the patient flow portal reporting through to us, which was sorted out today. So we should have more notifications coming through more reliably from today onwards. But yeah, it is a very limited service that we are going to be able to sustain, obviously because of the same problems everyone has got, which is that we just don't have the staff numbers to provide much more than what we have been providing.
Thank you, Mel. And I think this highlights, right across the state in all the meetings have been in at a state level and regional level. This really highlights that this is a disaster response that we've got to pull together, and meaning to say that things won't be perfect, but everything that we can do to pull together as a health system across both primary care and acute care, now's the time that we've got to make it happen. And this particular flowchart speaks to me that we as GPs know our patients who are at particular increased risk. We know our patients who have got, social factors that make things more complex for them. We know our patients who might not be able to access the smartphone or have Wi-Fi, or the credits run out all the time on the phone. And if there's any which way we can get messages out to our community via word of mouth or via social media or any other platform that lets them know that if they do test positive, particularly on a rat, that we're available to help support them get onto the right channels. So I guess within your own practices, have a little think about how that might come about, and your own community is the best, and the best ways to get the messages out to them. I'll just flick back now to the PowerPoint. So moving on, again, rapid changes. Our Western New South Wales Health Pathways has had to undergo lots of changes. And so people who might have logged into Health Pathways 2 days ago and followed the guidelines there in providing care for your COVID positive patients via virtual means, it looked different yesterday and looks different today. So log on and explore that. And that's really so that we can keep up with all the changes that are happening at the state level. And hopefully it looks a little bit simpler to navigate as well. It will continue to undergo changes day by day or every couple of days, or as quickly as I can keep up with updating that according to, as Dom mentioned, every few days there are changes happening at the ministry level, which we've got to adapt to. I'll invite Andrew now to speak through a few other things that the PHN have been working really hard on in order to support our general practices right across our Western and Far West footprint. Andrew.
Yeah, thanks, Ivy. Look, as others have said, COVID is a challenge that we're all trying to contribute to. As a PHN, we're doing a couple of things that we think is going to be helpful. We've put in place a nurse payment system to enable practices to essentially use their nursing staff to help monitor those COVID patients. We've got a very simple contractual arrangement in place. And for those practices that are interested, if they reach out to us, we can arrange that contract for you very quickly. We generate all the invoices, so the administration side is very low and it should be quite straightforward. That will bring a bit more income into the practice and should help you manage those large numbers of patients that you're likely to see. A couple of other things that we've got that is going to be helpful, I think, as we move forward. We are accessing pulse oximeters. So I know that many practices have been delivered small numbers, but if you do need pulse oximeters, we are able to deliver some of those to you. We've got a number on order, so we are spreading them quite thinly across the catchment, but that's something you can get from us. A really big change for us in the next week is we are starting to roll out fit testing for clinical staff. So we've bought the equipment, we've got access to the masks, and we're able to come out to the practices and do that fit testing for you. So we think that's going to be useful for practices, particularly as you get increase in numbers of COVID patients. Now, finally, one of the things that I'll talk a bit about is a shared care platform that we're rolling out called Inca. We've now got that across a number of practices, and the intention really is for that bit of software to help manage patients across that whole of system. So effectively, it's a shared care platform where we can make patient information available to any healthcare provider. Patients have all got access to it as well. So we're finding that very helpful, and we've got that underway in a number of practices already. So again, if you're interested in that, just reach out to us and we can come and install that for you.
Many thanks, Andrew. And a little bit further on that Inca Shared Care platform, what has been written into it specifically for Western New South Wales is a COVID patient self-assessment tool, meaning to say that you, via that link that's now available on the PHN website, you can direct patients to register on that link and encourage them to fill in the self-assessment questionnaire 2 or 3 times a day or whatever you feel might be appropriate. That will then feed into your view of the Inca patient health record, and then you'll be able to see whether there's any red flags that are coming up as they fill in the questionnaire. The questionnaire also does have directives built into it. So, for example, you know, if they've answered yes to the question, that when they stand up and walk around the room for 30 seconds and they're getting breathless, it actually tells them to call 000 so that they can access care when they're critically unwell. If they're having trouble, if they respond in that questionnaire that they're having some trouble in terms of reduced fluid intake, you know, that directs them to make contact with a GP and, you know, to be able to obtain advice about rehydration, etc. So do explore that and make use of it. Thank you to the PHN for funding all of these measures, because not all PHNs across the state are as supportive as what ours has been and continues to be. Okay, so moving on.
You're on mute, Ivy.
Sorry, was I on mute for all of that section or just then?
He was. We were trying to lip read you, Ivy.
Once a day, it's got to happen. Let me go back to that slide then. Not having a good technology day. Here we go. And I just wanted to flag the point that with that Inca patient self-assessment tool, via that link there that we GPs can share with our patients, it's just a link to a spot on the PHN website. But if we ask our patients to type in WNSW PHN, it will land them onto the home page of the PHN website, and then they search within the PHN website for Inca, and it'll come up with that self-assessment tool. If they register for it, they can actually then answer those sets of questions 2 or 3 times a day, or however often you want them to fill it in. And from there, you'll then see their responses on your version of the Inca patient record. It it also gives them directives though. So if they've answered yes to the question about getting up, when they stand up and they walk around the room for 30 seconds, if they're getting breathless, it'll actually pop up a directive that says, call 000. If they've answered that they're not managing to drink as much as usual, fluid output isn't as good as usual, intake and output isn't as good as usual, it'll encourage them to call the GP so that they can get further support around keeping themselves hydrated, etc. So just moving on now, we'll go on to talk about Sotrovimab and Budesonide therapy. Sotrovimab, of course, being one of the monoclonal antibody treatments, or MABs, as we've all come to know these groups of meds for short. I'll hand over to Mel Berry to talk us through what the current recommendations are with those.
Hi everyone. So I've been just adding into the chat, just obviously like in our group, we've lived and breathed COVID since August. So we've got a bit of corporate knowledge about it. Most of what I've written in there is our evidence. Some of it is anecdotal, but certainly just specifically about asthma flares. We're just seeing a bit of an imprint that patients who haven't previously had asthma since they were a kid are actually getting quite significant asthma-like symptoms when they get Omicron. So what we're going to talk about is monoclonal antibodies. So this is one of the possibilities that you can use with patients with significant comorbidities. And there's been some changes that's important now that people have become self-managed, and that your patients will contact you. So I just wanted to talk about when to raise up a patient to the community team if you wanted them to be considered for Sotrovimab or Renoprev, which is another monoclonal antibody. I'm just going to show you about one of the COVID evidence net guidelines. So I'll just share my screen for a second. Just bear with me as I work this out. Can you see that, guys? The disease modifying treatments?
Not yet.
No, can't see it. No.
No? Okay. Give me 2 seconds. I've got many things open to show you. And what can you see there?
Yep, we can see it now, Mel.
Great. What does it say? Because it's not showing me what it's showing you, essentially.
Disease modified treatments for adults with COVID-19.
Excellent. Okay, so essentially what we are looking at is whether a patient is going to be a candidate for Sotrovimab versus not a candidate for Sotrovimab. So 2 things. Sotrovimab is a monoclonal antibody. This evidence is based on one trial where they gave this antibody, which is primed to identify the spike protein to coronavirus or SARS-CoV-19 virus and help the body identify it as non-self. It's given as an intravenous infusion, and it needs to be given to patients within 5 days of onset of symptoms. So currently we often miss the boat because people don't get their PCR results in time or contact our team in time for us to actually enable them to be given treatment. But given that now people are able to do their own rapid antigen test and are hopefully self-nominating, they may actually contact our teams earlier and contact their GPs earlier. And if you get them within 1 to 2 days of onset of symptoms, then it's really great if you can let us know about them, because we can get this monoclonal antibody given to the patient. So as Western New South Wales LHD is probably given more Sotrovimab than most of the other LHDs, and we've worked out how to give it not only at base sites but also at remote procedural sites. So if you're able to contact us, and we'll give you the numbers of how to contact the medical leads, we'll be able to help you walk through the assessment of whether they'd be appropriate, and then we'll definitely be able to enable that patient to have it. Sotrovimab's been shown, and I have no shares in Sotrovimab, so it's been shown to reduce the hospital admission by 80%. There are specific guidelines around who receives this treatment. So either if you're an Indigenous patient greater than the age of 35 or a non-Indigenous patient greater than the age of 55. And then if you have significant comorbidities, and that would be New York Heart Classification score of greater than 3 to 4, severe airways disease, you're immunocompromised, you're pregnant, or you have renal disease, or obesity where your BMI is greater than 30. Now, there have been some recent changes today, which has just dropped today. So they used to say that you could only have it if you hadn't been vaccinated. They're recognising now that because there's vaccine wane, that if you have not had a vaccine within 5 months, then you should still be considered. And so we want people to know that even if your patients have had 2 vaccines, if they're very symptomatic with significant comorbidities, they're people that we're interested in looking at. And even if that means a conversation with the medical lead, and this will be different for Far West, so I don't know what their Sotrovimab model is, so they'll tell you what it is. But with us, if there's a patient that you just think, maybe we could do this, then we would 100% consider it, and let's have the chat about it, because after the 5 days, you can't use it. Just a couple of other things about Sotrovimab. So it has to be done with a nurse and a doctor, and they have the infusion for an hour, and then they have 4 hours of observation. The side effects are, the concern is that you can get a side effect of anaphylaxis. We've seen one patient get a rash, and we've given probably close to 100, I think, doses by now. You can give this treatment to children greater than the age of 12. It's licensed for. We will be giving it to a child tomorrow who's got significant obesity as a risk factor and lots of complex comorbidities. We've set up a Sotrovimab sort of group of clinicians who are specialists. So we have initially when we were given Sotrovimab, we didn't have very much of a supply. This is before the government had bought a significant amount. And so we have a sort of cohort of people that we discuss about each patient about who should get it. And that includes an infectious disease specialist, respiratory specialist, one of the COVID care team. We also had an ethicist, and we sometimes when the decisions are a little bit grey, do involve all of our team once again. The other thing is pregnant women. Pregnant women weren't specifically listed because it hadn't been tested on pregnant women, because there is a concern about the severity of disease in pregnancy, and certainly we've seen some pretty awful things happening to pregnant women. Certainly there's an increased risk of stillbirth, there's an increased risk of placental insufficiency, there's an increased risk of preeclampsia, and this is all sort of evolving. We do recommend if the women have significant symptomology or significant comorbidities such as obesity associated with their pregnancy, then they should be considered. And what I'm saying is I'm advocating for you to put your hand up for your patients if you're considering it, and let's have that chat and let's get them Sotrovimab if they want to be considered the way that they would consent, because really it's done on one trial and it's an evolving piece of evidence, is we tell them that this is new medicine, and we have a very specific way which we consent, and then we organise for them to have the infusion the following day. They can pull out, they can decide not to have it, and that's absolutely fine. In terms of Ronapreve, we haven't used Ronapreve because it's not any use for patients with Omicron, and unfortunately because we've got so many patients who've been tested with a PCR, they're not actually genotyping, which means we can't decide who's got Delta and who's got Omicron. If you have a patient which you 100% know has Delta, then you could use Ronapreve. And the good thing about Ronapreve, and I'm sorry, I think it's Casirivimab and Imumaribib or something like that, can be given up to 7 days. We have a small supply of that in Western New South Wales. It's given as a subcut infusion. And so there's a possibility, say, if you had a Delta outbreak in, say, a nursing home, you could use it. But because we haven't had much Delta, there's so much Omicron, we've been opting to use much more Sotrovimab, covering the fact that we know that that variant is better covered by Sotrovimab. Any questions about that?
Thanks, Mel. And in terms of efficacy, what do we expect with Sotrovimab in the Delta setting and the Omicron setting? Are they vastly different, or are they fairly similar in terms of effectiveness?
So we still know that's effective, but I don't know the exact numbers. I'd have to give you some of the data, but it's an evolving space. I think we should be really clear about Omicron. So I was talking to Jan Fazell the other day, who's one of the public health physicians who works quite closely with Kerry. She's sort of her second in charge. And she was saying essentially Australia is having the biggest outbreak of Omicron in the world. So the whole evidence space at the moment is developing in our country. So our understanding of Omicron is actually going to develop from our country's experience rather than what has been previously, where the UK's had, so the US has had, Alpha, and then India had Delta, and we could see what was happening. We actually are it for Omicron. So you had South Africa, but that was quite small compared to us. We're having rapidly escalating cases. So it's all a bit of a cook's feast to know what is going to happen. And so very regularly, as an ED physician, we have regular COPs and catches up with public health and also within the group, which I'm sure is happening within your own groups, about, what the symptomology of this disease is, what's happening with pregnant women, what we're seeing in terms of hospitalisation. So there's a lot of chatter at the moment about how much hospitalisation is going on. So from looking at the stats from New South Wales Health, we're seeing a much lower amount of hospitalisation, but still a hospitalisation rate. And the pleasing thing is we've got a much smaller amount of those people who do need hospitalisation requiring ICU. So I think the numbers from last week was around about 6% of total numbers of people who've got the disease are requiring hospitalisation. And I believe from last week's numbers, it was around about 6% needed ICU. So that's incredibly pleasing. But I think what the World Health Organization is very, very clear about is if you have 4 million people who have the disease, then 6% of that total number is still a large amount of number. And as an emergency physician who's just worked 2 days in an ED, there are a lot of people coming in now, like a lot. And a lot of them are worried well. And that's all about us getting good messaging and good understanding into the community. And a lot of them are people who actually do need to come into disease. The other thing I would say, and this is going a little bit off topic, is that I know there's been a lot of rhetoric about that patients that are going in have got COVID, but they don't need to go into hospital for their COVID. I think there's two things that are really important there. Firstly, in terms of a staffing point of view, if you need to look after a COVID patient in hospital, that still takes a huge amount of staff to look after that patient in comparison to a person who doesn't have COVID. And the other thing is that anecdotally, and I guess I don't have the exact numbers for per LHD or per hospital, but there are still patients who are getting respiratory compromise from COVID, whether it be Delta or Omicron. They are still getting it. They are not uniformly unvaccinated. There's a mix. And so there is definitely still people who are getting severe COVID for whatever reason, whether they're significantly immunocompromised. So it isn't just COVID plus. The other thing was we just wanted to talk about the use of Budesonide. So I'm just wondering if you could bring up that, because I'm struggling to see what I'm talking to. Ivy, you know how we were just talking about the risks for Sotrovimab and for Budesonide? I think this is really important if, and I can certainly send out the pathways again for you guys just to have a look at. To be honest, whenever I'm looking at a patient, I always have them up because there's so much associated with what are the criteria for Sotrovimab, what's the criteria for Budesonide. But if you have a patient who you're going to be worried about going from a mild COVID to a more significant severe COVID, so such a person such as who has COPD, but who's not in the severe category right now. So perhaps they've been doubly vaccinated, they've got quite a cough, they're starting to feel a bit breathless, but their SATs are okay. They're still eating and drinking okay. You don't think they need to go into hospital. They would be a good person to start on Budesonide. So it's a 400 microgram twice daily inhaled dose that you start them on, and this is based on the principal trial. And so certainly that's what's happening in the emergency departments. If we've got someone who's got some risk factors for respiratory compromise, or in the next couple of days or where they're going to start to worsen, then we would start them on budesonide. The other thing I just wanted to point out is we don't start people on dexamethasone if they're going to be discharged. We only start people on dexamethasone if they have an oxygen requirement. And that's the other thing I was going to say about Sotrovimab is once a patient has an oxygen requirement, it actually excludes them from being able to be given Sotrovimab. So that was a very small trial that they looked at, who got Sotrovimab versus placebo, but there was some small evidence that patients that did have an oxygen requirement actually did worse once they got Sotrovimab. Now, I don't have the reasons why for that, and I'd have to look closely into the evidence about, what were the confounding matters about that. But once someone needs oxygen, really they need to be in hospital, they need to be starting on dexamethasone, and then they need to be starting on other immune modulators to help them through their process.
Thank you for that really good update, Mel. That's so helpful. I'm just going to move our chat along because there's a couple of things that we just want to get through as well, and then open up to questions and answers. So I'll just go to sharing screen again. Okay, moving on, escalating care to the LHD COVID teams, but also getting some further advice is required. So this is a really quick summary. So I've broken this table up into the Western New South Wales LHD footprint and the Far West LHD footprint. So if we've got a patient, just looking at the first row there, patient who we're needing to refer for disease-modifying treatment, we want to make sure that we catch them in that window period. For Western LHD, please call that direct CCIC physician number. So you'll get Mel or one of the other three CCIC physicians. In the Far West, please call the physician on call via switchboard. If we've got patients, going back to that first pathway that the ministry put out, if we've got patients who for some reason are actually higher risk and need close monitoring, but they haven't been captured via the online questionnaires, and we need to escalate them to the CCIC team or the community team in the Far West for closer monitoring, those are those numbers to call. And then the next two are talking about red flags. Obviously, if someone's got red flags, i.e., they've dropped the SATs, they're breathless, they're dizzy, they're having troubles in terms of hydration status, etc. All those things are listed on health pathways. But obviously, if they're critically unwell, then they need to be calling 000 and going across to the hospital. And we need to be providing that clinical handover. If they're not critically unwell, let's see what we can do to keep them out in the community, but to give them advice as to how to keep safe. If we need further help with that, then to call on the physicians on the teams, COVID care teams at the hospital. There is also a state specialist advice number. It will probably be pretty inundated, but I guess it's just another avenue that we can tap into if required. So across the state, there's a COVID care at home support line. If you ring it, which I tested today, there's options 1, 2, 3, and 4. Basically, option 4 is if you're a GP and wanting further advice, press option 4. So on to COVID-19 patient resources now. I'll skip through this fairly quickly, but when New South Wales Health sends out a message to patients, it does give them a link to read, and it's worthwhile us knowing this information, of course, really well as well. So again, these slides will be sent out so you can click on these links and explore this further. These documents that I've taken screenshots of, they were only updated today, and they are being updated really, really frequently. So what you read today may be different in a week's time, and so on and so forth. But that gives the patient guidance around how to, I guess, a little bit of reassurance about how they can safely manage at home, what to watch out for, how to reach out for help. but also important information about the isolation, how long to do that for, notifying the close contacts, etc. There are also some phone numbers for patients to ring. Across the state, there's the COVID Care at Home support line. So same one that we tap into as GPs, except they press option 1 or option 2. Can't remember one of those, but it will get them to a clinician who will give them some advice. And so particularly, I guess, in the after hours period, if you haven't got something in place locally for that, that's something that they can tap into at a state level. There is also the National Coronavirus Helpline, so they can make use of that to in terms of obtaining advice if they're concerned about the symptoms or otherwise. But obviously, safety net for your patients. So if they're critically unwell, and let them know what exactly to look out for. But if you're using the Inca tool, that makes it easier. But if not, let them know, particularly breathlessness, chest pain. Don't muck about, ring 000 and get attended to. And just really quickly, a Cook's tour of managing healthcare worker exposure. Again, these documents are being updated really regularly. And as I understand it, this version that was released 31st December and 1st January has in fact it was undergoing review again at the moment. But basically, if you've got your staff, doctors, nurses, admin staff, or whoever else who's working under you at the surgery, who's got an exposure to COVID either in the community or within the practice, gives you some guidance as to what you actually might need to do to try and maximise safety for your staff and maximise safety for your patients. And then we'll move on to questions and answers. But can I particularly invite Alan O'Connor's Director of ED at the Far West Local Health District. Just, Alan, can I invite you to make a comment? About those things that we've talked about, in particular with accessing Sotrovimab, etc. Is there anything that you wanted to add there?
Yeah, I think it's important that we've got basically one port of call, which is our physician on call. I think our numbers at the moment don't really preclude us from relying very heavily upon our physician on call. So really for patients that need one of the MABs or that need hospital treatment, even if they local practitioner feels it needs to come through the emergency department, we're encouraging everybody to go via the physician on call at all times. Should said physician not be available for whatever reason, of course, then ring the emergency department. But really, we've got one point of contact in Far West because we're aware of how easy these chains can break down. So yeah, and as a backup, if there's any issues at all with getting people contactable and so on and so forth, the EDMS, whoever, either Tim Smart or whoever is in his place, in Tim Smart's place, is always available to discuss these patients. With respect to the criteria for the MABs, which you alluded to have changed in the West, I don't believe we've changed them in the last 24 hours, but I could stand corrected on that in the next little while. But I'm aware there's a lot of work going on around it, but I'm not aware we've actually finalized any changes. Thanks.
Thank you, Alan. I'm just having a little look at the questions and discussion on the chat there. The eligibility criteria for both Sotrovimab and Budesonide are actually written into the active care pathway with Western New South Wales Health Pathways, so jump into that and have a look. There's not anything written in there about Ronapreve at the moment based on the response with Omicron, but there will be something inserted into there in the not too distant future at the state level, is my understanding. There's a question from Meg. And feel free to jump in, any of our clinicians here. Those treating lots of COVID, are we seeing a typical day that symptoms peak? What does a typical picture look like?
I was just, commenting about that to Meg. So I think when we were looking after Delta patients, we were seeing, you could almost predict the day they would fall off the perch. So there was a sort of spike in day 5 to 7 and then a spike at day 12 where they had sort of inflammatory changes. That's a little bit shorter. So we know that the incubation period for Omicron is much shorter. So your time to onset of symptoms is shorter. And we're seeing that people develop more significant disease a little bit earlier. But from what I've heard, we still have that second week where people can get the inflammatory changes and the respiratory compromise. I haven't got a good handle at the moment on that sort of how I understood Delta, where, you knew that day 5 to 7 they were going to get, often they'd get some diarrhea, vomiting, and then they'd go on to get really bad respiratory compromise. I was talking to my colleagues who see all the patients with us in COVID care today, and what they were saying is they see sort of day 3, day 4, day 5, they start to get quite breathless. They start to look quite unwell, but for some reason, and this might be to do with vaccination, it might be to do with the the virility, I think, of the now new variant, is that they start to drop their stats, become more breathless, but then they just don't need to go into hospital like the patients with Delta did. And that might be because the vaccination is really good at stopping them from severe disease, and hopefully that's the truth, and also that the disease is adapting to sort of live with us rather than killing all of us off, I guess. So in terms of, I think there's also a little bit less diarrhea and vomiting than we saw with Delta. Certainly with kids, you're getting high fevers, and then they kind of bounce back nicely. And that's as much as we know so far, but I guess we're only a couple of weeks in at the moment.
Yeah, thanks, Mel. And certainly whilst the press, all they talk about is Omicron, we've got to be mindful that we've still got a trickle of Delta happening across New South Wales. Would that be fair to say? I think somebody quoted yesterday around 10% Delta still and 90% Omicron is the expectation, bearing in mind that genomic sequencing is not happening for all patients. It's only for a small proportion of patients at the moment.
So there's a couple of things there. So I think when we looked at the numbers 2 weeks ago, so it was sort of 20% Delta and 80% Omicron. And now this week, I think it's something like between 10 and 15% Delta and the rest is Omicron. So Omicron has, a survival benefit as it's much quicker to transmit. It's much better at doing that between people. And so it's moving through it has a survival advantage at the moment. So it probably will be the overwhelming variant at some stage. But certainly Southwest Sydney is seeing still pockets of Delta. And you'll still get pockets of Delta where there's unvaccinated. So pregnancy, unfortunately, we've got the highest amount of people in the pregnant community who are unvaccinated. So you're going to see pockets of whatever variants coming around. And the other thing is that we will have a new variant at some stage. One other thing, just to go with that, is I should probably say, look, I've got a master's in epidemiology, which is why I'm so interested in this and why I kind of got into this in the first place, as well as being an ED physician and being interested in disaster. But in terms of talking about when we're going to be coming out of an epidemic and moving towards an endemic state, I did ask this question the other day to one of the infectious diseases persons at the Sydney Kids, and I think I'm cautious about when that's going to happen, because if you look at the way disease works in an endemic state versus an epidemic state, you don't get these huge spikes in endemic, as everyone would know what I'm talking about. You don't get overwhelming, everyone's vulnerable to the disease. With the flu season, you'll see a few people getting really sick from the flu. You don't see the whole entire population get the flu, and that's what endemic is. And so from doing a little bit of research about where we're going to get to endemic, I think we're a little way off. So maybe, hopefully, with having Omicron, maybe everyone will get it, and then we will get to that point where everyone's got immunity via vaccine or by native exposure to virus, and then we'll go towards endemic. But I just don't know when we're going to get there, and I think it's possible that we'll have this peak now, and I think it's possible that in a couple more months, when we go back into winter, we'll have another peak, and it might be another variant. So that's a possibility, and I certainly haven't seen quite yet when anyone's predicting that we'll be quite completely out of this. I know there's a lot of chat about it, but I can't quite see it quite yet. Just not sure.
Okay, thanks, Mel. Umit and Alan, would you like to add anything else from a Far West LHD perspective? I mean, there's particular challenges, especially with some of the more remote towns. How do you see this playing out in terms of accessing sort of further care, and particularly if people need to be escalated from a more remote location?
Yeah, certainly from a community care point of view, we have a reasonably good setup at the moment. And Becky was going to talk to us, but I believe that she's having technology troubles. So Melissa Welch, I believe, is around, and she may well be able to comment on the community care aspect. If Melissa, I'm sorry to hijack you, Melissa, if you can hear me, but if you're around, if you could make a comment, and then maybe Umid at that stage.
It's just to build on what we were talking about earlier. We do have a process of seeing people in the community if they do need it, and we have had fairly good success in escalating care through the physician on call with our previous systems. So we are fairly confident that would continue with the new processes in place, but obviously we haven't dealt with the numbers and the volume that we're seeing now, so we're just sort of monitoring and seeing how that goes, but definitely still have that COVID community response happening in Broken Hill, and then we pop them up in remote sites as well as needed.
Thank you,
Hi
Melissa.
guys, can you hear me now?
Yes, is that you, Becky?
It is, sorry. I think I might have finally cracked the technology dramas. Apologies.
Fantastic. Did you have anything else to add in terms of the Far West response at present?
Yeah, look, I think very much as everybody said that we've got some nice pathways similar to Western. I think one of the things that I would just say to our primary care partners per se is not only also thinking about their acute concerns of our patients, but also that still ongoing social well-being, and particularly, while our isolation period has reduced down to the 7 days, but thinking still about some of those more vulnerable communities that may be actually going through other things like withdrawal or mental health has still been something that's really important for us to transition into this new phase at the moment. So I think probably just something that I think with our primary care partners and us as an LHD that we'll continue to adjust and manage as we move forward.
Thank you.
And there's just
a couple more questions.
Here.
I'm just going to pick up.
Sorry, just
go ahead.
One more thing. Just in terms of primary health place as well in the post-acute side of things, just to monitor what the ongoing effects of, I guess, post-COVID looks like for people, and we're looking at trying to have some pathways to refer through for things like allied health input and support for people if they are having ongoing problems after that 3-month mark. So it's I guess we're focusing on the acute stuff at the moment, but that ongoing care and support is something we need to continue to talk about as well.
Wonderful, really important. And I'll just add to that as well, Mel, thank you for raising that. Actually, one of the things that's come through from a sort of a state GP level is a discussion around just keeping an eye out for the multi-system inflammatory syndrome in children, that even though it's rare, it's quoted at about 1 in 3,000. It's yet to be revealed as to how frequently it affects kids with Omicron. But if you're seeing children in that sort of 2 to 6 week period post the COVID infection, just have that as a possible differential diagnosis in mind. Alex had a good question about managing face-to-face care in GP land for COVID positive patients. And Alex, if you don't mind if I take that one, in terms, I guess it comes down to assessing risk within your own surgery, and probably some of the key things include ventilation, your access to PPE, fit testing, what your air conditioning system is like within your surgery. And so I guess a lot of the discussion at a state level, again with the College of GPs, is about supporting GPs to say, look, if you need to see them in separate rooms, so some GP surgeries have brought in demountables, some have erected temporary tent settings. Some have gone, look, we'll only do that as a home visit so that it minimises bringing the risk of bringing those people into the surgery. Think about all those things. Carbon dioxide monitors to assess what your ventilation might be within your rooms, and consideration of certainly air cleaners is worthwhile. I can flick you some further documents around that, Alex, post-session. And there's just one other question there as well in relation to differences in immunity from vaccination, from infection versus vaccination there. Would anyone like to make a comment about that?
Yeah, it's Alan O'Connor here. How you doing? And I'm sure Mel has a comment on this as well. But it certainly seems to be the case, and certainly the belief, that immunity from vaccines appears to be more robust and potentially longer lasting than from the disease itself. And I must admit that's sort of counterintuitive to me, but I've actually looked into this a bit, and it seems to be true. I've just posted up a link to one of the first reports I saw on this, which is from the Morbidity and Mortality Weekly reports, and there may be more recent data and papers on this, but it certainly seems to be that the immunity from vaccines is as good at and probably better from the disease. Mel?
Yeah, look, I think that's really interesting. And I guess, yeah, I feel the same way as you, that it sort of feels counterintuitive. I think that people are a bit concerned when there was this chatter about Omicron being mild when there was an outbreak in South Africa, because there'd been so many more sort of innate infections rather than vaccinations in that population prior to the infection from Omicron. So how Omicron was going to work here in a predominantly vaccinated but disease naive population, I think I felt quite worried about, but it does seem that the vaccine works effectively. And I think it's really interesting. How many more vaccines and how many more boosters is just who would know, and how clever the disease is and how it can evade the next vaccine is the next thing. But certainly we now know that people certainly can get, Delta and then get Omicron, and get Alpha and Delta, then Omicron, and then possibly can get Omicron again if it's a slightly different variant. So, which makes it harder to know whether someone can be infected again. So it's hard when your patient comes in, they've just had COVID. We used to say, oh, well, you've had COVID, you're off for 6 months, but that's not the case anymore. I think it's down to now a month, or they've changed it between 2 weeks and a month. So if you get new symptoms, they're now saying you should consider it again. I think the one thing about all of this work is whatever you say, it changes, and it changes within a week. And I think that just is quite unsettling. But there we have it, brand new disease, brand new rules.
Very true. Very true. Okay, that hour has gone by.
Oh, sorry, Ivy. I was going to say that if everyone doesn't have access to this, there's the Critical Intelligence Unit, and possibly everyone already has that. And I'll post a link to that. But that is updated weekly on the latest evidence across the world and collated in a sort of very readable 5 minutes, probably not before you go to bed, about what's happening in vaccines, what's happening in disease modifiers, what's happening in treatments, and certainly can keep you updated. It also has a really useful dashboard of what's happening across New South Wales.
Good idea, Mel. I'll send that to Erica to distribute that link to the Critical Intelligence Unit resources together with the slides from tonight. But thank you so much, everybody on our panel, everyone who's jumped on board to this evening's session. You wouldn't do this on a Friday night except in the midst of a disaster response to a pandemic. Thank you for all taking part. Thank you for looking after our community so well. I'll hand over to Bruno now. Oh, sorry, Umit.
Anyway, if I can just come in. Look, my apologies. Being half an hour on the other side of the time zone, I completely stuffed it up. That's why I was late in joining. And these points might have been made earlier, but I just wanted to really reassure from, I guess, from LHT point of view and from Minister's point of view, that this is really it's a system-wide response, really, and it is really critical that we work in partnership and that we support our primary care partners really well in this, because we think if we can do that, they can be safely managed in the community without ever having to come into the acute setting. Obviously, the acute setting has a significant role to play as well when things escalate, and want to reserve that certainty for that. But having said that, have a lower threshold in terms of wanting to get advice. I mean, hearing Mel and Alan, they're so knowledgeable. So really, that is freely available, and we'd certainly encourage our partners in crime, so to speak, to really reach out and seek that advice whenever that's needed.
Thank you, Umit. Brina, handing over to you.
Thank you so much for attending tonight, for your time, and for your important contribution and insights. We really appreciate if you take some few minutes to give us a feedback about this session and provide us some ideas for next sessions. Thank you, Dr. Ivy. Thank you, Dr. Mel, and the other panelists, and have a great evening and a good weekend, you all. Thank you.
Thank you for the session.
Thank you all. Keep safe.
Thanks
Keep
very
well.
much.
Take
Stay
care,
safe.
everyone. Bye.